This video will cover the causative agents, transmission, and pathogenesis of typhoid fever. We will also discuss clinical outcomes, diagnosis, differential diagnosis, and treatment options. Typhoid fever is also known as enteric fever. It is primarily caused by Salmonella enterica serovar typhi and S. enterica serovar paratyphi, which are species of bacteria. If a febrile illness lasts more than 10 days and malaria has been ruled out, typhoid fever is often the cause. Vaccination is recommended before travel, especially to the Indian subcontinent. The disease is transmitted in a dose-related fashion, usually through food contaminated by feces or urine from infected cases or healthy carriers. Houseflies are common vectors, leading to higher prevalence during rainy seasons. All age groups are susceptible. The incubation period ranges from 1 to 3 weeks. Both the incubation time and disease severity are dependent on the bacteria dose exposure. After ingestion, the bacteria invade lymphoid tissues and disseminate to organs like the bone marrow, gallbladder, and spleen, where they reproduce in macrophages. Most pathology occurs in the gut, resulting in inflammation, necrosis, and ulceration. Classic symptoms begin with fever and headache, progressing to high fever with chills, cough, abdominal distension, and myalgias. Interestingly, most patients present with constipation rather than diarrhea, alongside prostration. Differential diagnoses for typhoid fever include malaria, typhus, viral hepatitis, amoebic liver abscess, and other types of infective enteritis. Classic signs include bradycardia relative to the fever, though this may be absent. A pale red macular rash, called rose spots, may appear on the trunk after several days. As the disease progresses, patients may develop splenomegaly, leukopenia, and elevated liver enzymes. Complications of typhoid fever can include small bowel ulceration, anemia, DIC, pneumonia, meningitis, myocarditis, cholecystitis, and renal failure. Diagnosis relies on clinical assessment and investigations. These include blood culture, urine culture during the second week, stool culture, and rose spot aspiration biopsy. Bone marrow culture is the most sensitive diagnostic method. Current antibiotic recommendations are ceftriaxone, 2 grams IV every 24 hours for 14 days, or ciprofloxacin, either 400 milligrams IV every 12 hours for 10 days, or 500 to 750 milligrams PO twice daily for 14 days. Alternative treatments include azithromycin, either 1 gram PO on the first day followed by 500 milligrams PO daily for 6 days, or 1 gram PO daily for 5 days. Cefixime is another option, at 10 to 15 milligrams per kilogram IV every 12 hours for 8 days. Due to antibiotic resistance, treatments such as ampicillin, trimethoprim sulfamethoxazole, and chloramphenicol are no longer considered reliable. For severe typhoid fever with delirium, coma, shock, or DIC, corticosteroids are administered. This involves a dexamethasone loading dose followed by subsequent IV doses over 8 administrations. Supportive treatment includes IV rehydration and blood transfusion in case of serious gastrointestinal bleeding. If left untreated, mortality is 10 to 15%, mostly in young children. The information presented in this video is sourced from the Oxford Handbook of Acute Medicine, Kumar and Clark's Clinical Medicine, Muhammad Enam Danish Medical Diagnosis and Management, and Davidson's Principles and Practice of Medicine. If you have any questions, please feel free to ask. Thank you for watching this video on typhoid fever.